Welcome everyone to this important seminar of the organized but on CKD-MBD, Back to the Future, and which vitamin D for which patients, which is a critical topic that will be addressed by Dr. Silverio Rotondi and covering important aspects on what will be the optimal vitamin D levels in CKD patients and what will be the best agents to provide the adequate amount of vitamin D to correct vitamin D insufficiency, and what have we learned about how to suppress PTH and what are the risks that we need to avoid. That will be an in-depth coverage by Dr. Rotondi from the University of La Sapienza in Rome, Italy. We will have Dr. Mario Cozzolino and Dr. from University of Milan, Italy, and Dr. Markus Ketteler from Stuttgart, Germany, as the panelists who are experts in the CKD-MBD working group that have a major experience in these critical topics. And I hope that the seminar will help you have an easier time when having to give indications to your patients for the best outcome with minimal risk. As a matter of fact, one administrative indication is that a reminder to all participants that by participating live in this seminar, you will earn 1 European credit for your continuous medical education. This is an exclusive benefit for the ERA members. And without further ado, I would like to introduce our main speaker, Dr. Silverio Rotondi.
Thank you for your kind presentation. And thanks to the CKD-MBD working group for the opportunity to participate in this seminar. As anticipated, we will talk about vitamin D in patients with chronic kidney disease, not on dialysis, with a look to the future. This is my disclosures. The subtitle of this presentation could be Vitamin D, the Eternal Story. In fact, the first scientific description of a disease linked to vitamin D dates back to 1645, when the morbus glorum, called rickets, is described for the first time. The disease was evidently already known for some time. For example, in this painting by Caravaggio of 1608, Amorino Dormiente, we can recognize some characteristic elements of rickets. Disease that became endemic in England in the early 1800s due to urbanization and the exploitation of the child labor. And in the 30s, the sun-produced vitamin D was identified as the antirachitic vitamin. In reality, the link between vitamin D and life is much older if we consider that the first form of life, 800,000 years ago, already presented cholecalciferol, probably linked to the cellular energy metabolism. Over the millennia, the endocrine system vitamin D has become an increasingly complex, acquiring a new function, regulation of immunity, metabolism of calcium and phosphate. So vitamin D and vitamin D receptor appeared in evolution before our transition to vertebrates. This emphasizes the importance of vitamin D systemic action. In addition, we can say that what we are now is closely linked to vitamin D. In fact, 40,000 years ago, when sapiens migrated from Africa to Europe, they differentiated into 3 populations. The selective path toward this phenotype was probably the different ability to synthesize vitamin D, depending on the activity of the DHCR7 enzyme. This introduction to emphasize that vitamin D is fundamental for life. The endocrine system of vitamin D has evolved for 800,000 years, developing a fine and strict hormonal regulation. So we must add a link with care. Today, we know that vitamin D originates from the skin in an amount that depends on the activity of the DHCR7 enzyme. It is then hydroxylated in the liver, becoming calcifediol. The kidney completes the second hydroxylation to calcitriol, the form of vitamin D considered active in calcium phosphate metabolism. We also know that these steps are closely modulated thanks to the presence of degradation system of the various precursors. In particular, the regulation of renal calcitriol synthesis is complex and modulated by at least two main hormones, PTH and FGF23. We have also to remember that the parathyroid cell and monocyte have the capacity to convert vitamin D to 25 vitamin D. So there could be a total activation of vitamin D locally, first to 25 vitamin D and then to calcitriol. That will not change either circulating 25 or 125 vitamin D levels. It has long been known that patients with chronic kidney disease develop alterations in mineral metabolism, characterized by biochemical, bone, and vascular abnormalities. These alterations identified in a CKD-MBD syndrome are relevant, leading to an increased cardiovascular, fracture, and mortality risk for our patients. Alterations in mineral metabolism were considered an event of advanced CKD, characterized by increased phosphatemia, decreased calcitriol, and calcemia, resulting in increased PTH. Today, we know that first alterations of mineral metabolism can be detected from the early stages of CKD, such as the reduction of alpha-klotho and the increase of FGF23. It has also been shown that as CKD progresses, there is an association with reduced circulating calcifediol levels. Among these alterations, particular attention is given to the control of secondary hyperparathyroidism. In fact, as shown in this graph, increased PTH is associated with increased mortality and fracture in CKD patients. The latest KDIGO guidelines of 2017 suggest evaluating phosphate, calcium, and PTH together for the therapeutic choices. And although they do not identify a reference value for parathyroid hormone to be obtained in patients with CKD, they suggest to act if PTH shows a progressive increase or is consistently above the reference limits. In fact, the chronic stimulation of the parathyroid gland can lead to development of a nodular hypertrophy no longer responsive to medical therapy. This is aggravated by hyperphosphatemia that acts directly on the calcium-sensing receptor, reducing their activation. We must prevent this event. Well, but what are the stimuli that cause an increased secretion of PTH? Certainly hyperphosphatemia, but we could consider it a late phenomenon of vitamin D that cause the reduction in serum calcium and therefore the stimulus to the secretion of PTH. What type of therapeutic intervention can be performed on vitamin D? Clearly, we can act on different levels. Let's start with nutritional vitamin D. From this recent meta-analysis, it's evident that therapy with nutritional vitamin D allows to increase the level of 25 vitamin D in patients with CKD on dialysis. This is a very good result. In fact, the guideline suggests correcting vitamin D insufficiency. And we also have shown that adequate levels of calcidiol are fundamental for life in general, regardless of chronic kidney disease. However, we must remember that in patients with CKD, there is a reduced hydroxylase activity, also in the liver. As shown in this study, liver cells in an uremic environment produce less calcidiol even after the addition of nutritional vitamin D, which is confirmed in experimental kidney disease. This indicates that to achieve adequate levels of calcidiol in patients with CKD from nutritional vitamin D, we should use higher doses than in general population. Moreover, this also partly justifies the low efficacy of this repetitive therapy on control of PTH. As evidenced in this meta-analysis, where nutritional vitamin D therapy obtains a minimal reduction in PTH values, probably not clinically relevant. Well, let's try to skip this step to use immediate release calcifediol as therapy. In fact, calcifediol allows to rapidly increase circulating 25 vitamin D levels more quickly than nutritional vitamin D, as shown in the graph. About the increased levels of 25 vitamin D with calcifediol, it's interesting to remember that several groups have demonstrated that in kidney disease there is an impaired conversion of 25 vitamin D to 24-25 vitamin D, despite higher 24-hydroxylase expression. And if we evaluate the effect of the percentage reduction PTH during therapy, we realize that the effectiveness of calcifediol at immediate release is poor. In the graph, you see the results of 3 studies that used calcifediol in patients with CKD. It's evident that the percentage decrease in PTH compared to the baseline values is modest and reaches values of 20% only with doses of calcifediol probably at the limit of toxicity. These results are probably related to the fact that the increase in circulating calcifediol levels obtained with this therapy are too rapid. As I described earlier, the endocrine system of vitamin D has evolved for millennia, developing defensive regulatory mechanisms. In fact, in the graph shows how in the course of therapy with immediate release calcifediol, 25 vitamin D levels increase rapidly after a few hours. This leads to a rapid increase in calcitriol levels, which, however, is counteracted by an equally rapid increase in FGF23 and therefore of vitamin D catabolism pathway. This is highlighted in this last graph, where we see the increase in the activity of CYP24A1, the catabolic pathway of vitamin D. This defense limits the activity of this therapy. Given the limits of the therapy with nutritional vitamin D and the immediate calcifediol, let's try to use directly the active vitamin D, that is calcitriol or analogs, in particular paricalcitol. Also in consideration of the fact that, as evidenced in this work by Pasquali, in patients with CKD, there is a reduction in the ability to synthesize calcitriol from the substrate calcifediol. It's evident that, unlike the general population that, despite the reduced levels of substrate, manages to produce adequate level of calcitriol, in patients with CKD, there is a substrate dependence of the hydroxylase system. This is an additional reason to use active form of vitamin D directly. As expected, based on what we said about the pathophysiology of secondary hyperparathyroidism, calcitriol reduces PTH values. In the graph, we see the reduction of PTH linked to calcitriol therapy in patients with CKD. However, an increase in FGF23 is associated. In fact, calcitriol-tested mice, highlighted in fuchsia, present reduction of PTH, but increase in calcemia, phosphatemia, and FGF23. So, in this case, to achieve a positive effect, we get 3 negatives 1. In the 2 randomized controlled trials, Primo and Opera studies, paricalcitol was used to evaluate cardiovascular outcome at a dose of 2 micrograms daily. As expected in both studies, the use of paricalcitol results in the reduction of PTH, but the therapy is associated with numerous episodes of hypercalcemia. In fact, a recent meta-analysis led by Professor Cozzolino showed that therapy with active vitamin D, in particular paricalcitol, at the average dose of 2 micrograms daily, increased the risk of hypercalcemia in CKD patients not on dialysis. In the vital study, always in non-dialysis CKD patients, the use of paricalcitol, always effective on parathyroid hormone, led to increase in serum calcium and phosphatemia. This is also confirmed in other studies in CKD population, in which an increase in FGF23 also found where calcium phosphate product increased at at least 10 mg compared to the baseline. What does this evidence can tell us? That active vitamin D therapy is unequivocally associated with the reduction of PTH, but also with the risk of hypercalcemia, hyperphosphatemia, and increased FGF23. Elements that today we know to be strongly involved in the pathogenesis of CKD-related vascular damage, that increase the risk of cardiovascular events and death, and that we must therefore avoid. So, vitamin D is not for everyone. According the last KDIGO guidelines suggest more attention on the use of active vitamin D in patients with CKD non on dialysis, limiting the use of these drugs in advanced CKD stage and severe hyperparathyroidism. So, what can we do? It is clear that, as suggested in this review of the literature, if a patient do not present alterations of mineral metabolism, we do not have to do anything. If it has vitamin D insufficiency without alteration, PTH, calcium, and phosphate, we can use nutritional vitamin D. But if there are alterations of the PTH, what shall be done? As we have seen, different vitamin D therapy that can be used have strengths and weaknesses that, in some cases, are more serious than the strengths. We should look for an ideal therapy that allows us to increase the level of 25 circulating hydroxyvitamin D, reduce PTH without negatively affecting calcium, phosphate, and FGF23. Recently, a new form of calcifediol has been proposed. It is called extended release calcifediol for its pharmacokinetic characteristics. As we can see in the graph, unlike calcifediol, the black line, ERK, red and blue lines, causes a slow increase in circulating level of 25 vitamin D, which result in a more gradual increase in calcitriol levels. This led to less activation of the catabolic pathways, less increase in FGF23, and less vitamin catabolism. The first randomized trial involving 78 patients with CKD showed that the treatment with extended calcifediol involves, in a dose-dependent manner, both the increase in circulating level of 25 hydroxyvitamin D and the reduction of PTH. You see that about 60% of patients treated with ERK at 60 micrograms daily have a 30% reduction in PTH. And it's interesting to underline how the increase in blood levels of calcifediol during therapy is modulated over weeks, making it more physiological. The results were confirmed in this randomized double-blind controlled trial that included 429 patients. The graph shows how the treated group increased calcifediol value with a reduction in PTH. In addition, in a second phase of the study, open label, patients previously treated with placebo or introduced ERK therapy have, like the previous group, an increase in calcifediol levels and reduction in PTH. With the result, at the end of the study, of a reduction in PTH greater than 30% in half of the patients treated, without increase in calcemia, phosphatemia, as shown in the graph, but also in FGF23. In a post-hoc analysis of the study, dividing the population into quintiles of circulating calcifediol levels, the authors highlight that a significant reduction in PTH is obtained when the calcifediol blood value were 50 nanogram per minute, perhaps a new minimum target for CKD patients, always in the absence of significant increase in FGF23, which in any case reaches level above 60 picogram in the fifth group. Moreover, in the first two quintiles, most of the patients were in the placebo group of the study. This is an element to be taken in account in the interpretation of these results. Therefore, extended release calcifediol may be a future therapy for this group of patients. However, we try to propose a reflection on the topic which vitamin D for which patients. In fact, like the dark side of the moon, there is the dark side of the graph. If 50% of patients respond to therapy, however, 50% of patients will not respond. We must therefore ask ourselves why, and if the treatment with these responsive patients will be harmful, and if we have some elements to identify the different types of patients before starting therapy. So let's take a step back, looking to what stimulates the secretion of PTH. Of course, the vitamin D alterations and hyperphosphatemia, which is a late CKD-MBD alteration, but also the reduction of phosphate clearance, which involves an alteration of the serum phosphate pool, This may be an early and hidden event that also justifies the experimental evidence of early FGF23 increase in CKD. In fact, normally, when we introduce a phosphate load with diet, rapid control system prevent the formation of circulating calcium phosphate crystal. This led to the formation of complex called calciprotein particle 1 that stimulate FGF23, leading to an increased phosphaturia, reduced calcitriol, and therefore reduced the intestinal absorption of calcium and phosphate. All this without any significant modification of phosphatemia. On the other hand, CKD patients present despite a normal phosphatemia a basally increased phosphate pool. In this case, the nutritional phosphate leads to the formation of more complex particles, called calciprotein particle type 2, which promote inflammation and also an ever greater escalation of FGF23, which causes a greater reduction of calcitriol synthesis and increased phosphaturia. The increased phosphaturia in a patient with a reduced number of nephrons, however, leads to an increase in intratubular phosphate concentration, which, if reaches critical thresholds, will be risk factor to progression of renal damage. In a patients like this, increased phosphate pool, elevated FGF23, critical increase in intratubular phosphaturia, would you give vitamin D? But how do we identify it? We cannot measure calciprotein particle 1 and 2 in our patients, but we can estimate the concentration of intratubular phosphate. In fact, as anticipated, if the intratubular phosphate reaches limits value, it will result in formation of aggregates that causes renal damage with a receptor-mediated mechanism. This concentration, called PTFP, can be estimated with a simple formula that take into account phosphaturia, creatininuria, and creatinemia. Some studies have proposed estimated PTFP thresholds as indicators of the increase in FGF23 and possibly of kidney damage. This is a maladaptive situation. So it's possible to think that patients resistant to therapy are patients with greater pool of phosphate, not evidenced by phosphatemia alone, and therefore with a greater activation of vitamin D catabolism pathway, FGF23 mediated. In these patients, calcifediol therapy does not work and may even be dangerous. I would like to ask you, it's time to think at the phosphate pool and estimate it in our therapeutic choices? So, to conclude, the endocrine system of vitamin D is complex and finely regulated. We are looking for an ideal vitamin D treatment for secondary hyperparathyroidism. The various forms of vitamin D available have advantages but also limitations that reduce their use. The extended release calcifediol seems to have significant advantage, but in future therapeutic choices, we might not be satisfied with simple phosphatemia, but try to evaluate the phosphate pool of our patients. Thank you for your attention and time. Allow me to thank Professor Mazzaferro, Dottoressa Pasquali, and Dr. Tartaglione, who helped me in the presentation of this report. Thank you very much.
Let me tell you that it was a very important presentation with many things. And now it's our aim to try to summarize the major points, because, you know, several publications, vitamin D is always important topics, not only for nephrologists, but for medicine in general. And my first comment is about the vitamin D that we prescribe in our patients. And I really think that it's important to go for patients with CKD early stages, CKD late stages, and then dialysis patients and kidney transplantation. So looking at the physiopathology and the therapy that we have, I think that one of the messages could be that in early stage, as KDIGO comments, probably we should considering our population like normal renal function. I don't know if Markus, you agree, until CKD stage 3A probably, and we can replace 25D levels. But then when PTH started to be high, that is the time probably to change our attitude with the the treatment. So this is my first point. And I don't know if Markus, you agree or you have major things to comment.
Let me agree. And I think we have two issues. We have to avoid clear-cut vitamin D deficiency as in the normal population, maybe also addressing issues like immune function, cardiovascular themes, all these pleiotropic effects, but definitely for bone health in general, preventing osteoporosis and so on. But then we have the issue of progressive secondary hyperparathyroidism. And this is a complex and difficult topic because we don't know the target PTH. We know the dynamics that needs to be hampered and stopped, but on the other hand, we need some elevations in PTH levels in order to keep on our patients having phosphaturia and to keep the bone going in an appropriate way. And this is probably one of our major difficulties we have to address. But I think we can now turn over back to Adriana, what she would like us to say and to know, and how we should further work up the presentation of Silverio here.
I think that you were making the right point. I don't know why I got disconnected. It was a period of fear for me. And I think that the most important message to clinician is what are the risks using the different forms of vitamin D according to Dr. Rotondi's presentation that we need to take into consideration with supplementation. The like cholecalciferol, ergocalciferol, and the hydroferrol or 25-hydroxyvitamin D and the slow release calcifediol are our tools. Is there anything that we need to consider, and what is the PTH levels that we should consider that we need to initiate treatment, and what will be your suggestion for supplementation according to the vitamin D stage of these patients and the degree of renal failure, of course?
Should I start maybe?
Yes.
Okay. I think the PTH target levels are stage dependent. So the worse the kidney function, the higher they may get. But the problem is that they should not rise in an uncontrolled fashion. That's one point. The other point is that there are indications, for example, also still, despite the caution that the KDIGO guidelines from 2017 implemented, to use pericalcitol, calcitriol, and so on, especially in patients who have very low calcium levels, so hypocalcemia with a progressively rising PTH, and who have some kind of control of the phosphate levels at the same time. However, patients who have a more or less normal calcium and maybe go into the situation where phosphate already starts to rise, they may have difficulties with the classical active compounds, and here this intermediate compound may play a role, the slow release or extended release calcifediol. However, what we learned from these pivotal trials was that we require maybe a 25 OHD level of above 50, which would be a new target to have actions on PTH. And then the question arises, what would be the case if we achieved this level of 25 OHD with, for example, giving higher amounts of vitamin D3? And we don't know whether this unique pharmacodynamic, pharmacokinetic structure or action of extended release calcifediol is so unique that it's only effective this way, or whether we have just to change the target levels for, let's say, CKD4 to 25 OHD or 50. And I think this is one of the unanswered questions.
Yes, if I can, I agree with Markus and with the comment by Adriana. Also, I like the idea of the age. I will extend to the phenotype of the patient. So considering that probably we can have two different phenotypes. One can be patients with CKD stage 3, in which there is a kind of older age. I'm not talking about malnutrition, but with in which PTH can be high because really the levels of 25D are extremely low, and these old people they need to have to be supplemented with nutritional vitamin D, and probably good reduction of PTH is still there when CKD stage 3, 3A, and some of these with 3B. The second phenotype is the younger, relatively younger patients that the nutritional state is normal, and in which PTH can go up because the phosphate load and we listen a lot about this FGF23 story, but probably we should have more data to go for clinical use and routine use of FGF23. This second phenotype is someone that probably the first action is to control phosphate load to have better control of PTH, and then see when is the case to start with an active form of vitamin D. One of the major things is that the KDIGO was commented about the risk of hypercalcemia with active vitamin D, CKD stage 4 and 3B, when we need to use high dose of active vitamin D to suppress PTH. So this is very well recognized. So when we increase the dose of active vitamin D, we can have the risk of hypercalcemia in this population. With nutritional vitamin D and with low dose of active vitamin D, the risk of hypercalcemia is moderate.
One important point is in CKD, we have a defective uptake of 25-hydroxy by not only by renal cells, but because of the insufficient megalin that is going down in CKD. So that will reduce the amount of 25-hydroxy to synthesize 125. But there is also a demonstration that despite the increase in 24-hydroxylase, you don't have an increase in 24-25 levels. So you have an impaired degradation of 25-hydroxy. So when you provide levels of 25-hydroxy higher than 50, as apparently is a new recommendation to correct PTH, what will be the risk of having a competition between 25-hydroxy and 125 for catabolism? The 24-hydroxylase catabolizes 125. So we will have an excess of 125 catabolism, an increased amount of 25-hydroxy that could not be that effective. So how can we reduce the risk of these patients to increase 25-hydroxy levels that will impair the efficacy to suppress PTH? And that's why we need higher and higher 25-hydroxy to get the level of PTH that we would like, is 30% suppression of PTH, and how that will increase the risk of hypercalcemia.
I think that I need to go back in one of the first data that with this new formulation of extended release calcifediol we have. And I think that they were measuring also 24, 25. And I think that between the two formulation of immediate or extended release, there were some differences in this aspect, Adriana. So probably it's not only the molecule, but also the formulation that can be one of the way to answer to these points, right? So I think that this was demonstrated with some preliminary experimental data that were published a few years ago with ERC.
And as Dr. Rotondi mentioned, there was the quintiles of 25-hydroxy gotten by the slow-release calcifediol were related. The second quintile, first and second quintile had 96% of patients having placebo rather. So my point will be, what is the actual increase in 25-hydroxy that you reach with 25-hydroxy at the slow release 25-hydroxy compound? So why it was used a quintile for placebo-treated patients? So we don't get a % of patients responding, which is what we need to know if we want to correct vitamin D. So do you have any comment about that? Because you did an outstanding, both of you did an outstanding review of the pharmacology of this compound. So any comments about that?
I mean, a few comments maybe. And I think that the effect on 25-OHD levels and PTH levels consequently is dose dependent. Second, it's dependent on the stage of and the GFR, because the key issue on the PTH effect, if this is how it works, is that exactly the 24 hydroxylase metabolism is not turned on in a way as it is with acute loading of vitamin D. And that leads to a relatively intact hydroxylation of 125, which again works in a way to suppress PTH. That's at least the concept of the compound. However, whether this is really unique to this pharmacological or pharmacodynamic procedure and capsule needs to be, I think, still proven in a head-to-head comparison with the more conventional forms. And on the other hand, of course, with advanced renal function, the toxicity of overactivating 25-OHD levels is limited, because the loss of kidney tissue and secondary the high FGF23 levels continue to suppress the 125 hydroxylation in an uncontrolled way. And so I think this is an intermediate which may have some positive consequences for clinical treatment strategies.
The other major concern that I have is that in some studies, in normal people, when you try to correct vitamin D deficiency to correct muscle strength and reduce the number of falls and fractures in these patients, you have certain levels of 25-hydroxy that of cholecalciferol administration, or even small doses of 25-hydroxy that will correct those defects. However, when you start giving 400 micrograms of 25-hydroxy, given that it is not the slow release, so your point is very well taken, Markus, there was the opposite effect. So that an increase in 25-hydroxy will reduce 125 production, non-renal 125 production, because of increased catabolism, and you will have the reverse effect to what you are trying to get. So my point is just to be cautious about the levels and the indication of increasing 25-hydroxy, because as Dr. Melamed showed in a group of women, when you overcome the 50 nanograms per ml limit, you have an increase in the mortality rates rather than a reduction. So it's just to point to the audience that we need to be cautious and to use as many instruments as we can have in a regular nephrology unit to prevent toxic effects and the increase in hypercalcemia and hyperphosphatemia that we are trying to avoid by giving active vitamin D or that we cannot reach with cholecalciferol. So any particular comment for physicians to be cautious? What would you suggest that they should do?
Yeah, if I can, I mean, looking at data that came also from the real world after the trials that were made by extended risk calcifediol, in which they were just starting with mean levels up to 20 nanograms, that in real practice, really, we start to give nutrition and anti-vitamin D around 5, 10, 15. So, and we want to go up to 30. So percentage is similar. The first time that I saw the results in which patients were to 60 or to 70, I say, wow, this is very high levels of 25D. So I agree with you. The data in which also Silverio was discussing today about when you have 50 nanograms, you can have better control of PTH. This was the kind of post-hoc analysis. So I agree with you that we should be cautious about giving numbers to our colleagues today, which levels of 25D reach to control PTH. So in this sense, I agree. We need to make more studies. I agree with Markus, also comparison between different compounds.
Yes. And in relation to what Dr. Silverio was analyzing to check on catabolism by measuring ratios of 24, 25, 25 hydroxy levels, that is impossible to do in clinical practice because not all institutions have that possibility. Is there any way that you would suggest how can we control for what will be the main markers that you would like to suggest to be taken into consideration to make sure that there is no increase in catabolism, that we are not reducing the amount of 125 that we have to suppress PTH locally when giving these high amounts of 25 hydroxy? Any recommendation?
Simply calcium and phosphate. So that needs to be monitored, but otherwise I would never start thinking about looking at the metabolites in individual patients. This would go far beyond what we would like to reach in our patients. This is at least my point of view.
And what will be the level of PTH that you want to control according to the CKD stage? Is there a special association between level of PTH that you would like to recommend?
Adriana, you know that how the guidelines were thought about. There is no level, there is no target. There is only the stability of disease, and this is individually and stage dependently and age dependently and diabetes dependently different. So there is no number that can be given. What we need to address is autonomy protection. And so we need the trends and the serial assessments. We need to take care that the phosphate is not going up and the calcium is under control. And then I think we are in a good shape. But on the other hand, when looking at the clock, we should possibly take also a look what is asked by the audience. Meanwhile, I see we have 8 questions here. So would you like to take a look there?
Yes, thank you. The first question is, why no mortality or cardiovascular benefits with vitamin D and B in CKD patients? Would you like to answer?
I think that also Silverio can participate.
Yes.
I mean, my comment is that I'm not surprised to see the differences in mortality in our population, because there are so many risk factors that only the question is between D and B. We can also have C, A. I mean, it's not possible. But so I'm not surprised, and I don't think that any trial will go in this direction, right? So it's very difficult to demonstrate benefits in survival. Even I don't think that there are data in general population that vitamin D can improve survival. So
Silverio, would you like to answer?
Yes, I completely agree with Professor Cozzolino. We have a lot of factor risk in our patients. It's difficult to find one thing that can modulate it. So I agree.
There is another question: why phosphorus management doesn't affect CKD-MBD markedly?
Because it has not been investigated so far in a prospective manner, and studies are out now who do that. We just have a huge amount of epidemiological data that phosphate management may have an impact on mortality and survival, but no cause and effect studies. The only piece of data is that we have from the Cosmos trial, where patients over a 3-year course of observation who were treated with phosphate binders and who had a better managed phosphate metabolism also had an improved outcome. But there was no control group. This was just a randomized single-arm prospective epidemiological trial. But we need these trials, and they are ongoing in Canada and Australia, at least as far as I know. And we might give an answer to that in about 3 or 5 years.
One of the participants is asking if testing FGF23 and clotho levels are available in the market. Would you like to comment?
Silverio?
Silverio.
Yes, if there is the possibility to test it. This is the question. Yes, of course.
Yeah.
FGF23 is possible, but clotho, no, clotho just for research aims. It's not possible to test it in our patient, but FGF23 is possible also in clinical practice, of course.
And regarding clotho, there is also huge variability with the assays available, so we cannot have a consensus on what are the levels, and there are contradictory data in different clinical trials.
Yes, and if I can say also about the FGF23 levels, I think that it alone say a little thing, because we have to check if this FGF23 has an action on our body or in this in a specific patient. For this reason, I underline the role of phosphaturia and intratubular phosphate, because alone a single value of FGF23, I think isn't useful. We have to check the effect of this hormone. This is my opinion.
That's a very important point, and you did a very important observation by presenting that data and the tools that we have with measuring the phosphorus effect. They are trying now, there is sodium phosphate co-transporter inhibitors to decrease phosphorus reabsorption for proximal tubules. Is that okay to decrease serum phosphate levels, or can provocate kidney disease?
These compounds are, it's tenapanor, isn't it? And this was just stopped by the FDA for further development. It's effective to lower phosphate. It has side effects like diarrhea, but currently it's neither available nor in a real prospective status for future approval.
There was a prior question on the what vitamin D will you provide in case of patients receiving denosumab?
Well, actually, the denosumab in at least in hemodialysis patients, data are a few. Some are coming from Japan, some studies, and I think that we should be careful. But in patients with CKD stage 3, again, I do not have problem to consider if they have diagnosis of osteoporosis to use. And then what is the supplementation of vitamin D? So I think with cholecalciferol, it's fine, like in the general population. So probably if we want to considering CKD stage 4 and the CKD stage 5 non-dialysis, single cases, case by case bone fractures. So in this sense, we started to use denosumab. And then no problem, I think, with kidney transplant patients, because they also can use bisphosphonate. So this is what, but it's very important to make diagnosis of osteoporosis and look at the bone fractures risk in patients.
Yeah, and this should be a high turnover osteoporosis. So patients should be, most of them have also hyperparathyroidism, which is treated. But if they have a high fracture risk, it may make sense with the denosumab. But one needs to be aware that in the dialysis situation, the rate of profound hypocalcemia is very high. So I usually consider treating patients at least 2 to 4 weeks with an active vitamin D compound prior to using denosumab in order to stabilize their calcium. Otherwise, they may drop quite tremendously.
Yeah.
I would like to say that in this case, I think we also to think at the bone biopsy for the orientation on the therapy choice in our patients.
Another question is in CKD patients, if phosphatemia is high and 25 vitamin D is deficient, would we give vitamin D despite hyperphosphatemia?
Well, short answer by myself, yes. I mean, about again cholecalciferol, and it's clear that if this is CKD, is not usual to have high phosphate levels in CKD, no dialysis. So, what I can say that I will, if it's deficient, yes, I will use native vitamin D.
Me too.
There is sorry.
I agree.
There is another question talking, I think that Mario, you referred to that previously. What is the benefit of using vitamin D alongside with active vitamin D in CKD patients?
I think that the benefits of using native vitamin D in CKD patients in CKD stage 3 is to do both, to increase levels of 25 and reduce PTH. The thing that also in the publication that we did, we try to see now, probably with this new formulation, extended release calcifediol, we don't need to use both forms of vitamin D. So in some patients, to give cholecalciferol plus paricalcitol, now we can use extended release calcifediol to have both effects and to reduce the risk of hypercalcemia. This is what in CKD non-dialysis is possible to do by now.
Yes, and it's important what you mentioned, that if you give only calcitriol or the analogs, you are not correcting vitamin D deficiency. So this slow release calcidiol could give us the opportunity to correct both. There is one question, and is there ongoing or completed trials regarding vitamin K in MBD?
We have to see. The VitaVasc study just came out, I think, a month ago, where progression of arterial calcification could be prevented by vitamin K1 in hemodialysis patients. Although this trial finally was only a very small pilot trial, I think a little bit more than 30 patients finished it. But even with these few patients, these results were quite significant. And especially because they showed that MGP, which is the target of vitamin K activation, really seemed to get activated by this mode of action in this trial. However, we need not just looking at calcification progression, but on hard outcomes. That would be the appropriate way to address this. For this, we needed a much larger trial. So it's still preliminary. Where we use it, or where I use it always, is in patients with calciphylaxis. I give it to them because they are probably vitamin K depleted, and at least those patients who develop calciphylaxis under the use of a vitamin K antagonist, they are and remain depleted if they are not substituted consequently. And so this is a situation where I use it in CKD patients, but not as a routine agent.
I think that we are getting close to the end of the presentation. I hope that we have covered all the important topics for the audience. Important to remember that we need to correct vitamin D deficiency and to be cautious about what will be the best vitamin D metabolites that we need to minimize the risk, optimizing the capacity to correct PTH and the other pleiotropic actions of vitamin D. And the control of phosphorus, not only serum phosphorus, but as Dr. Rotondi pointed, clearly the renal excretion of phosphate that could affect renal damage and the progression of CKD. So correction of vitamin D is important, and correction of PTH is important, and how we do it without risking the security of our patient in phosphorus level FGF23 is an assurance that we are not affecting the cardiovascular risk or the risk of progression of kidney damage. So I thank everybody for your participation,